Hello, it's Bruce Williams, and today I want to present part 4 and the last lecture in my series on the selected gross pathology of the endocrine system, in which we are going to discuss the adrenal glands. As I do at the beginning of all of my lectures, I want to thank those friends and colleagues who provided me wonderful images over the years, either directly or through online collections, which allow me to make these lectures available. Let's start this lecture with a little bit of advice, and I've learned this the hard way many times. Retrieve the adrenal glands early in the autopsy, before the field gets bloody and messy. Can't tell you how many extra minutes I've spent going back through tissues trying to find the adrenal glands I neglected at the beginning of the autopsy. So harvest them first. Okay. We're looking at the adrenal glands from a neonatal non-human primate. There is extensive hemorrhage and necrosis within the center of the gland, which in an adult animal would be the medulla. In neonates of many species and fetuses, they have two zones of the cortex. The fetal cortex, which provides most of the steroids needed for fetal development and parturition. And then they have a thinner adult cortex around the outside. At birth, the fetal cortex will begin to degenerate and break down. And it will be replaced by a cortex with the familiar three zones that we're used to. The involution of the fetal cortex is accompanied by necrosis and hemorrhage. Other potential causes of hemorrhage in the neonatal stage may be stress due to birth trauma or a number of infectious agents. We're looking at the adrenal gland of a foal, and you can see that there are large areas of hemorrhage and necrosis within the adrenal gland. There are a number of viruses which we need to consider that will attack the adrenal cortex of animal species. In horses, especially foals, you want to think about equine rhinopneumonitis or equine herpes virus type 1. Herpes viruses are well known in a number of species for causing adrenocortical hemorrhage and necrosis as part of systemic disease. It's very common in dogs with canine herpes virus type 1, basically in any animal species which has a systemic syndrome associated with an alpha herpes virus. You can often find nice inclusions in areas of necrosis within the adrenal cortex. Another alpha herpes virus that causes disease in bovine neonates is infectious bovine rhinotracheitis virus, or bovine herpes virus type 1. In abortions in any species, it's important to make sure to get those adrenals, and like I said before, get them first. They're always a great place to find herpes viral inclusions. Pigs, you'll see herpes viral inclusions in association with suet herpes virus type 2, the causative agent of pseudorabies. So look for herpes viral inclusions in the adrenal cortex. I've seen them in adult dogs with systemic herpes viral infections. Another well-known cause of hemorrhage and necrosis in the cortex of adult animals, especially large animals, and especially the horse, are bacterial infections in what's been called the Waterhouse-Friderichsen syndrome, which is usually seen in humans. In horses with endotoxemia, due to a wide range of gram-negative organisms like salmonella, like actinobacillus E. coli in young animals, you will see the effect of endotoxin on endothelial cells, especially profoundly in the adrenal cortex. I always say endotoxin wax the endothelium, and that's what it does. One of the major effects of endotoxin is to cause endothelial damage, necrosis, and subsequent thrombosis, and you'll get large areas of infarction in the adrenal cortex of animals with endotoxemia and the syndrome known as Waterhouse-Friderichsen syndrome. You can occasionally see this form of hemorrhage and necrosis in, as we said before, birth trauma in neonates, any severely stressed animal, such as horses dying from overexertion. If you've seen the other lectures in this lecture series, you'll recognize how refreshing it is to be able to talk about something other than hypoplasia, hyperplasia, neoplasia, and endocrine glands. But I'm about to run out of interesting slides. We're about to start hitting those three categories in the adrenal gland as well. I do have one more slide of a fungal infection, an older image from Dr. Ross Terrara at the California Regional Primate Center, which shows marked granulomatous inflammation affecting the adrenal gland. And this was a case of coccidiomycosis, a disseminated fungal infection that is prominent on the west coast of the United States, now extending down into Mexico and Central America. Other bacterial or fungal infections will hit the adrenal gland. I've seen a number of cases in ferrets over the years of granulomatous inflammation within the adrenal cortex in which mycobacteria were retrieved. And my opinion, impression, not backed up by any references, is that because of the production of cortisol, it may be an area in which you have local immunosuppression in the cortex, and it might make this part of the body a little more susceptible to bacterial or fungal infections. Another rare case of granulomatous inflammation that you may see in the adrenal cortex would be in hairy vetch toxicosis in cattle and rarely in horses. Often affects the adrenal cortex. Okay, talked about some great infectious disease lesions associated with the adrenal gland. Now it's time to go down our usual path of hypoplasia, hyperplasia, and neoplasia to finish this lecture. Remember, we have two parts of the adrenal gland, so we're going to talk about those three categories first in the adrenal cortex, then we're going to move on to the adrenal medulla. Here is an adrenal gland from a dog. And one of the general rules, which is applicable to most species, I'll say all species, is that the cortex and the medulla and the other cortex should be in a ratio of 1 to 1 to 1. Obviously, we can see that here it's 1 to 6 or 7 to 1. This indicates that the cortex is markedly thinner than normal. And we're talking about marked cortical hypoplasia. Cortical hyperplasia can be divided into a number of different categories. One is primary versus secondary. In cases of primary adrenalitis, you see damage in all three zones of the cortex: the glomerulosa, the reticularis, and the fasciculata. These are usually primarily immune-mediated processes, and the animals are deficient in both glucocorticoids and mineralocorticoids. They are the Addison's animals. Now, Addison's can be diagnosed obviously through clinical pathology. A very simple test, not always specific because there are a lot of other diseases that will cause this, is looking at the ratio of sodium to potassium. If it's less, then you'll hear all sorts of numbers. I like 20, some people say 25, some people say 17. This suggests a lack of mineralocorticoids and the suspicion of primary hypoadrenocorticism should be there. But remember, there are a lot of other different diseases that may do that, including whipworm infection, renal failure, uroabdomen, hemolysis, phosphofructokinase, and this is just in the dog. It's a nice screening test that works well in textbooks, but in real life, you often have to do a number of other tests. Adrenal hyperplasia can start early in life. There are two different syndromes in cattle, which are generally characterized by prolonged gestation because of marked cortical hypoplasia. The reason that the adrenal cortex does not develop in these animals is because they have pituitary cysts, and the pars distalis of pituitary, which releases ACTH, is never formed. And we've talked about this in the lecture on the pituitary gland. So these animals don't have functional thyroids, they don't have functional adrenal glands. And the steroids produced by the adrenal gland are a major mover and shaker in parturition. Okay, both of these calves were from prolonged gestation, and this can last from 3 weeks to 3 months. One of these animals had a 440-day gestation before delivery. There's a marked difference in these two animals. In Guernseys, the fetuses are generally delivered hairless. Even though this animal was taken past term, development stopped at about 7 months for this particular fetus, even though gestation exceeded 300 days. The result of no ACTH stimulation from a pituitary which never formed. There's a slightly different pathogenesis in Holsteins, in which you have an enzyme of 17-hydroxyprogesterone, which is produced by that fetal adrenal cortex. The fetus is actually a giant. This animal stayed in for 400 days. A lot of hair, bony deformities because it just got so big. And once again, though, the fetal adrenal gland is hyperplastic. And this is a picture of what you might see in one of these calves carried too long because of a lack of production of steroids from the hypoplastic adrenal cortex. Let's get back to our dog for a second. When we talk about primary hypoadrenocorticism, idiopathic immune-related disease is the most common, often seen in standard poodles. And these syndromes, which are seen in a number of breeds of dogs, start very early, maybe as early as 2 months after birth. They will have profound lymphocytic infiltration of all 3 zones of the adrenal cortex. Now, they don't generally show clinical signs until about 90% of the cortex is lost, and the signs are usually due to loss of mineralocorticoids. As a result of the derangement of sodium potassium that we see, generally associated with hyperkalemia, you may see cardiac abnormalities in affected individuals, including severe cardiac dysrhythmias. When we talk about secondary causes of hypoadrenocorticism, or a very small cortex, the number one, the overwhelming cause is due to the administration of excessive amounts of iatrogenic corticosteroids. There will be bilateral loss of the adrenal cortex on both sides. Because there is a lack of ACTH production. The amount of corticosteroids is telling the pituitary stop producing ACTH. And so it stops, and you'll have a bilaterally, often severe, decrease in the zona glomerulosa and the zona fasciculata. Generally, the mineralocorticoids are preserved. That outer layer, the zona glomerulosa, is not affected in iatrogenic causes of hypoadrenocorticism. The animal may show external clinical signs of hyperadrenocorticism because of all the steroids that some veterinarians have been pumping into these animals. But when you look at the adrenal cortex, it's going to be very small. Another cause of secondary, and a rare cause of secondary hypoadrenocorticism, is going to be other diseases that destroy the pituitary, the source of adrenocorticotropic hormone. Okay, you're still going to have an adrenal with very small cortices. The mineralocorticoid producing zona glomerulosa will be maintained, but the other two layers will be shot. This is what we see in dogs, very much like those calves, which have a lack of formation of the pars distalis because of improper development of the oropharyngeal ectoderm of Rathke's pouch. These are those small, foxy-looking dogs with puppy hair coats or no hair coats, with open physes, and with very deficient development of thyroid and adrenal cortex. You can also rarely see it in animals with large pituitary tumors, which destroy that part of the pars distalis, which secretes ACTH. One other, actually not that uncommon, cause of secondary hypoadrenocorticism is going to be the administration of OPDDD or other drugs in order to treat cortical hyperplasia. A little too much, tough to dose, and you will wipe out the adrenal cortex. It's not just a dog thing. Here is a case in a horse due to excessive amounts of administration of exogenous steroids. In horses, you can also see a transient adrenal insufficiency associated with critical diseases, and it's more of an impaired response to cortisol than a lack of production. Okay, we've covered adrenal cortical hypoplasia or atrophy, both the major causes of hypoadrenocorticism. Let's now look at hyperplasia of the adrenal cortex. Here's a benign form of hyperplasia that's extremely common in older dogs, horses, cattle, and this is a nodular hyperplasia, often of the zona glomerulosa, but it might be other parts of the adrenal cortex as well. These are non-functional areas. They don't cause any problem for the animal. They do not operate out from under the effect of ACTH, and you will not see any concomitant decrease in the size of the adrenal cortex. It's just, in dogs, a little too much zona glomerulosa. Usually, it may extend through the capsule, doesn't mean anything at all. You might also see nodules within the cortex histologically, which may be mildly expansile, compressing the surrounding tissue. Doesn't mean anything in terms of hyperfunction of the adrenal cortex. And here is some in a horse. Hey, look at the color of these. Remember that any tissue that produces steroids is going to have a yellow-orange appearance. And that's because one of the major components of steroids is fat. And when you oxidize fat, which you have to do to turn it into steroids, then you get a yellow to orange discoloration. So let's talk about hyperfunction of the adrenal cortex in the species in which it is best documented, most often seen, and that's the dog. Let's take a look at these adrenal glands on the bottom. Remember, it's supposed to be 1 to 1 to 1. This one's 5 to 1 to 5. That's too much cortex. 80% of the cases of Cushing's disease in the dog or adrenal cortical hyperplasia are the result of lesions in the pituitary gland. These tumors used to be called cortical adenomas. A good name, a benign neoplasm of pituitary cells that produce excess ACTH. 90% of these tumors are benign. You can tell as we talked about in the lecture on pituitary tumors, very difficult to, and there are no great guidelines for diagnosing pituitary carcinomas. You're looking for extension and infiltration of the overlying brain or the underlying bone. But getting back to spontaneous Cushing disease, 80% in the dog, great number to remember, are pituitary dependent. This dog, you might also see some neurosigns. If this pituitary tumor grows upwards, it causes pressure on the optic chiasm, resulting in visual deficits or blindness. You could see pressure causing on the hypothalamus, causing diabetes insipidus, and a loss of growth hormone in this pituitary lesion may result in what's known as pituitary cachexia. Sometimes when the hyperplasia of the adrenal cortex gets especially bad, you'll see pressure by the expanding glomerulosa and reticularis, the reticularis and the fascicularis on the overlying glomerulosa, resulting in decreased levels of mineralocorticoids. If 80% are pituitary dependent, that means that 20% of Cushing's disease are the result of a functional cortical adenoma. Very nice nodule right here. It's yellow just like the surrounding adrenal cortex. And remember that not all adrenocortical adenomas are functional. First thing to look at is when you look at these adrenals histologically, look at the cortex of both adrenals. Sometimes you will see areas of nodular hyperplasia, which will be multiple, and in humans the biggest nodule is often called the dominant nodule, but it doesn't necessarily mean that these are functional. A good clue that you're dealing with a functional adenoma, if you did not have the history of this animal showing signs of Cushing's disease, hair loss, thin skin, torn skin, calcified skin, and all the other things that go along with Cushing's, is to look at the adrenal cortex, either of this gland or the other gland. If this particular tumor is functional and secreting cortisol, you are going to see atrophy of this cortex and the contralateral cortex. Let's take a look. Does this look like 1 to 1 to 1? No, it doesn't look like 1 to 1 to me. So in addition to this adrenocortical adenoma, we have ipsilateral adrenocortical atrophy, suggesting that this one is functional. Okay, a couple things about adenomas. You can see them bilaterally in dogs. They're occasionally cystic or necrotic. They will not invade adjacent tissue, but they will compress the adjacent tissue within the cortex. Adrenocortical adenomas are very common in a number of species. Laboratory rodents get a whole lot of them. They also get Pheos, which we'll talk about in a couple of minutes. Cattle get a lot of adrenocortical tumors, and we'll talk about adrenocortical tumors in cattle in just a moment as well. This isn't a ClinPath lecture, but you will often see increased levels of cortisol. You'll see an increase ACTH stim in about 50% of them, and usually no response to low-dose dexamethasone tests. High-dose dexamethasone is a great test for these. They don't respond to it, but pituitary cases will often suppress. Remember, it is not the secretion of cortisol that has any effect on the cortex, but the secretion of cortisol works with a feedback loop with the pituitary gland, letting the pituitary gland know that there's plenty of cortisol. It doesn't have to secrete ACTH, and that is what results in the shrinkage and atrophy of this and the cortex on the gland on the other side. Here's another picture of one adrenal gland with a very large functional adenoma and loss of cortex on the other gland. Adrenocortical carcinomas are not anywhere as common in the dog as adenomas are. They can be functional, they can be not functional. There is not a really good histologic way to tell carcinoma from adenoma. Generally, they're much larger, and the key is the invasion of adjacent tissues. As we said before, histologically, tumors often recapitulate normal tissue very well, and the difference between benign and malignant is not something that you can do very well with a simple biopsy without a good history, a measurement, knowing if there is metastasis. Adrenocortical carcinomas in dogs tend to metastasize fairly readily. They often tend to invade the vena cava, and they may invade the kidney as well. Another species that gets a lot of adrenocortical tumors, not to include people because you get them too, but adrenocortical carcinomas, especially with a propensity to metastasize to the lung, are cattle. Been a number of good papers. This picture is taken from a paper from the Journal of Comparative Pathology, but there's been a number of them in veterinary pathology as well, looking at adrenocortical tumors in cattle. Criteria of malignancy that were used in these papers were invasive growth into the capsule, vascular invasion. People used to say, "Oh, Pheos invade the blood vessels, and cortical tumors don't." That is not true. They both will do it. So invasion into local vasculature doesn't really help differentiate between a pheo and a cortical tumor on a gross basis, at least. Okay, so invasive growth into the capsule, vascular invasion, a diffuse growth pattern, a spindle cell morphology, and nuclear pleomorphism. So that was used as the criteria. I think the best of that is, you're going to have size, you're going to have local invasion, and in cattle, they love to go to the lungs. To pad this lecture a little bit, I'm just going to show some of the things that you will see in dogs and cats with Cushing's disease or adrenal hyperfunction. One of the classic signs in the dog is loss of the hair coat, thinning, mineralization of the skin, especially starting over the neck and the dorsum. You'll see increased bruising, decreased wound healing, comedone, increased infections, a lot of things going on in the skin. You'll also see mineralization of other parts of the dog's body. It sort of parallels what you would see in an animal with renal failure, because you will see mineralization of the wall of the stomach, of the skeletal muscles, and most tragically of the alveolar septa, because when you have any mineralization of the alveolar septa, that part of the lung is non-functional. Here's a fantastic picture from Dr. Paul Stromberg showing a piece of dog skin with this very reddening, scabby-looking mineralization. And the cause of the mineralization isn't really established yet. I think that the best theory out there is that the excessive levels of cortisol will produce a change in the tertiary structure of collagen, predisposing it to mineralization. A wonderful picture here from Karen Morello of a lesion that you might see in a cat with Cushing's. You can also induce it if you put enough steroids into a cat. Sort of cute, but you get this ear folding, maybe a weakening in the collagen of the ears. This is a cat thing. Just a fantastic picture. Something that's a little more serious that has been well documented in cats with adrenal hyperfunction, adrenal cortical hyperfunction, is feline skin fragility syndrome, a tearing of the skin, which can be somewhat small here or obviously massive defects. It's also been associated with the occasional case of FIP, but most of the cases are associated with hyperadrenocorticism. Okay, tumors don't just arise in the adrenal cortex. They also arise in the adrenal medulla. We call them Pheochromocytomas. Histologically, people will divide these into medullary hyperplasia, which is much more of a thing in laboratory animals than it is in small animals or large animals. I don't use the term medullary hyperplasia very much at all, if ever. They can be relatively benign, and the vast majority are relatively benign neoplasms that arise within the adrenal medulla. I want you to look at the difference in the appearance of this particular tumor. Whereas the adenomas are often yellow because they're making steroids, the pheochromocytomas are not. They're whitish tumors. They very often have areas of hemorrhage and necrosis within them. So you'll see a lot of hemorrhages. They don't just, at least in the dog, they don't just arise in the adrenal medulla. You can also see them in the sympathetic ganglia. And they are often accompanied by other neoplasms of the endocrine system. We've talked about multiple endocrine neoplasms. This is one that you almost always see in cases of MEN. And there are a wide variety of different syndromes involving tumors of the pituitary gland, tumors of the thyroid gland, or the pancreas, or the adrenal gland. But they almost always have pheochromocytomas. The vast majority of these tumors are clinically silent. They don't cause any clinical signs, or at least imperceptible clinical signs. And there aren't very many straightforward tests for identifying functional pheochromocytomas. The vast majority are identified at autopsy, and the animal never showed any clinical signs. This is one in the old days. If you had trouble differentiating it, you might put some potassium permanganate or Zenker solution on them, and it'll turn them a brownish red, where it won't do anything with the cortical tumors. You can also see them in horses. Okay, so they will be functional. The animal will sweat. You may see cardiac hypertrophy. We've seen a number of cases with vascular damage within the heart, and clinically they'll sweat, they are tachycardic, and it's probably the result of liberation of excessive catecholamines, catecholamines being the functional hormone produced by the adrenal medulla. You see them in just about every species. Very nice one picture from Fernando Castillo of a pheochromocytoma. Look, it's whitish with a lot of blood and hemorrhage. Although I know cattle get a lot of adrenal adenomas, I'm leaning toward Pheo in this case as well. Bulls are well known for multiple endocrine tumors, including Pheos and calcitonin-secreting C-cell tumors of the thyroid gland, one of the classic MEN syndromes. They may be associated with pituitary adenomas, and Guernseys and Holsteins. Both are overrepresented with these MEN syndromes. Pheochromocytomas are very common in New World monkeys, especially cotton-top tamarins. And then finally, it's an extremely common neoplasm in old rats. A number of chemicals have been used to incite the formation of these tumors in old rats, including xylitol, sorbitol, reserpine, vitamin D3. One other little oddity about rat medulla is that whereas the medulla in pretty much every other species is divided into cells that either produce epinephrine or norepinephrine, and you can tell the difference by the location of the granules within the cells on EM. Rats have cells also in the medulla which don't care. They secrete both of them. That's just a little unusual thing. You can also, in rats, have tumors which are called complex pheochromocytoma, which are characterized by a large component of proliferating medullary cells, typical pheochromocytoma, and a coexisting component of variably differentiated neural cells resembling either a ganglioneuroma or a neuroblastoma. That's the complex pheochromocytoma. As we said before, in animal species, don't get suckered in because a adrenal tumor is going into the vessels. This one was a Pheo. This is one that's in a lot of the textbooks, but cortical tumors, cortical carcinomas will do it just as often. Other tumors of the adrenal cortex or the adrenal gland, in case they do happen, this is a cow, it's a big fleshy tumor. This is just lymphoma. And now I have been saving one of the oddest situations in the adrenal glands for last. Here's a bald ferret. You probably knew that. And ferrets have a distinct condition which is very unique, only shared by some species of rodents and, of course, people in the animal kingdom. And it's not traditional Cushing's disease, although many of the outward appearances, including that bilateral truncal alopecia, patchy alopecia, may resemble Cushing's disease. Their condition is known as adrenal-associated endocrinopathy. And it is not because of the liberation of cortisol. Only a few ferrets with proliferative lesions of the adrenal gland will release any cortisol. But they release a mixture of sex steroids, including testosterone, estrogen, and 17-hydroxyprogesterone, which as a constellation cause a number of clinical signs, hair loss being one. Here's a severely affected animal. And I know that there's a market for this animal, the nude ferret, I suppose. Problem is that it takes 5 to 6 years to get to this phase. So the, probably not a cost-effective field to go into, producing these nude ferrets. Okay, so the pathogenesis in these pictures are from a great article in VetPath written a number of years ago looking at the pathogenesis of this lesion in mice and ferrets. And this particular lesion is the result of early neutering and removal of the gonads. Now, how does that work? Well, ferrets they go seasonally into estrus, and every year there is a surge in FSH and LH as the days start to get longer to bring the animals into season. So the FSH and the LH is secreted by the pituitary gland, and it causes a hypertrophy of the gonads and bringing them back to full function so the animal will have it's litter. Well, luckily you don't have to worry about FSH. Really is not part of the picture. But when you remove the gonads, whether it is the testes from the males or the ovaries from the females, you don't get that push of estrogen or testosterone in response to LH to shut down the pituitary. So it keeps secreting more and more luteinizing hormone, waiting for that message of steroids that will never come. Now, after a couple of years here, after 2 or 3 years of this, the adrenal cortex finally just says, heck with it, I'll go ahead and produce the sex steroids in response to this constant bombardment with luteinizing hormone. And the lesions that we see in these animals are generally, initially the cortex becomes hyperplastic, ultimately may develop into an adenoma or a carcinoma. And it's all due to this push on of LH from the pituitary. I'm sure there are spontaneous adrenocortical tumors in ferrets, which have nothing to do with this feedback loop like there would be in every other species, but the majority have to do with early neutering. Now here's a little quiz for you. Which of the animals has adrenocortical disease? Exactly, this one. Absolutely hairless. Now, the hair loss is the result of the effect of estrogen on hair follicles. Other outward signs that you'll see in these animals is they may, even though they've been neutered for years, they may revert to asexual behavior, mounting other animals. Externally, females that have been neutered may have marked hypertrophy of the vulva as a result of the receptors for these sex steroids on fibroblasts, which may result in hyperplasia up to 400 times normal size. Okay, so that's the story of adrenocortical neoplasms. At least from a clinical point of view, histologically, the vast majority of them, although they will histologically resemble carcinoma, are only metastasize very late in the course of the disease. It's very interesting that ferrets have a large number of carcinomas, and the clinical signs are similar whether you have a focus of hyperplasia, whether you have an adenoma, or you have carcinoma. You have the hair loss, you have the return to sexual behavior. You don't, interestingly, have the bone marrow atrophy that you think about when the animals have high levels of estrogen. That doesn't seem to happen in ferrets, or it does very rarely. And something this big often histologically resembles carcinoma, and you can diagnose a carcinoma. The thing about the carcinomas is that they rarely metastasize. They metastasize very late in the course of disease. So the removal of a carcinoma generally is associated with a good prognosis. You get it out. Okay. These animals will often develop additional tumors on the other side, resulting in bilateral adrenalectomy. We were taught in school that you bilaterally adrenalectomize an animal, it's going to die. Ferrets have a lot of ectopic adrenocortical tissue scattered throughout their body, and they adapt very well to monthly injections of mineralocorticoids. So bilateral adrenalectomy should not be frowned on in ferrets with adrenal disease, because they do very well with monitoring and mineralocorticoid injections, and some don't even need that. Other things that you might see in the adrenal gland of ferrets is a great picture by Dr. Unita Bryant, a very unusual situation, which is unique to the ferret. In the right adrenal gland, often in hyperplastic adrenal glands, you will see cystic areas which are lined by biliary epithelium. These are biliary rests, and over the course of time in the animal, they will secrete a very viscous material. And then the surgeon will go in to do adrenal gland surgery or something like that, and he'll note this big nodule on the adrenal, take it out and send it to you. Sometimes they just pop out this sort of waxy, homogeneous eosinophilic material, and to submit that. And if you get something like that, it doesn't even have to have tissue attached to it. And you notice from the right adrenal gland, it is the secretions of these adrenal cysts that are seen in hyperplastic right adrenal glands. Very unique to ferrets, and I get a number of questions about this. And the animal may or may not have had adrenal-associated endocrinopathy, but removing this is not going to help that situation. This is just something very different, and they are biliary cysts within the right adrenal gland. And then finally, just for fun, whereas most animal species like to put their teratomas in the gonads, that's where you mostly find them, the ovary or the testis, rarely at the base of the ear in horses. Ferrets are going to be different, and the teratomas that you see in ferrets will be in their adrenal glands as well. And this is one we published a series of a number of years ago. This is the histology, and right here you can see a tooth embedded in bone, and if you looked in this animal, you had haired skin within it, you had gut and lung and all sorts of things. So ferrets do everything weird in their adrenal glands, and throwing teratomas in there is just another day in the life of a ferret. And that brings us to the end of the lecture on adrenal glands. It brings us to the end of the lecture series on the gross pathology of the endocrine system. It's not a great system for gross pathology. A lot of the same stuff over and over. Hypoplasia, hyperplasia, and neoplasia. But I've enjoyed putting it together. I hope you've enjoyed these lectures. Thank you very much once again to my good friend Don Mutin, who has been just a great inspiration in terms of learning endocrine pathology, in terms of learning clinical pathology, a very giving and an outstanding teacher who I hope he doesn't mind me using so many of his images that he's taken over the years, and I hope that I've done justice to that. It's going to be a couple of weeks. I'll be back later on in the spring, and we will be doing the gross pathology of the cardiovascular system and finish with the musculoskeletal system before summer comes along. I hope you'll come back to see those lectures. I hope you go and look at some of the other lectures that I've been able to put together on other systems or animal species, and you'll come back on a frequent basis to the Foundation's YouTube channel and Facebook. With that, thanks so much for hanging in there, and I'll see you again soon.